My topic today is obstructive sleep apnea. I want to talk about the implications a little bit and then go through assessment and guidelines in the latter half of this. And real briefly, I have nothing to disclose, but to remind you of the objectives, what I hope to accomplish with this particular talk is to better inform you of the impact of obstructive sleep apnea, not only on the general population, and that's where most of the literature is, but also its impact on maternal health, on the fetus, and ultimately on the neonate itself. Also, I want you to be conversant on what the screening tools are out there, because you may well find yourself using them. The gold standard in assessment is not something that people will do easily, and so oftentimes you will find yourself at somebody's bedside trying to determine if this is an issue for them or not. And the question is it very sensitive to do this? Is it very specific to do this? And I hope to help you with that. And then to conclude with some management options when you're dealing with these types of patients. To accomplish that, I'm going to start off by talking about the pathophysiology of obstructive sleep apnea, what its medical sequelae are, how that impacts mom, the fetus, and the neonate, go through the diagnostic criteria, and then management itself. So what do we know about obstructive sleep apnea? Number one, it affects an awful large portion of the population. It's estimated to affect roughly about 20% of the population. Now, these are not people that are all diagnosed with it, but these are people that appear to present with the symptoms of it. It produces profound effects on the cardiovascular, the metabolic, and the neurocognitive systems. And this is where most of the research seems to be. But unfortunately, it seems to be a very complex interplay of all sorts of things. The anatomy, the neuromuscular tone, and how the oropharynx and hypopharynx function, mechanical as well as chemical factors. The other thing that makes this particular topic so difficult is that it really needs more research than is currently out there. And it is happening, and I'll point out to you as we go along. But even the criteria of what constitutes obstructive sleep apnea is not standardized. There are three different basic criteria out there. One is the Chicago criteria, another one is the Wisconsin Sleep Study criteria, and another one has been put out by the American Academy of Sleep Medicine. And they're all different. And the other aspect of this that makes it difficult is most studies will only look at one variable. But as I've just said, this is a complex interplay of many variables. So it becomes very difficult to really take one study looking at one variable and saying it has any true impact. The other thing is that this is not a disease of the obese, but it appears that obesity in and of itself escalates the process. And I'll get into that in a little bit more. But as I was trying to research this and put it together and look at the basic science, as I said, there's a lot out there that doesn't seem to make a lot of sense, a lot of things that are contradictory. So in my simplistic way of doing things, I came up with this little diagram to help me kind of put together what the potential pathway is. We all know that desaturation causes a pro-inflammatory state. So when you get into situations, and I apologize to all of you over there, I'm going to be concentrating my pointer over here, but you get into situations where you have repeated hypoxic episodes. What it starts to do is cause this inflammatory-based arterial remodeling. And the more that these episodes occur, the more you get an effect on the smaller vessels and then the larger vessels, to where eventually you start getting increases in intima and medial thickness of the large vessels themselves. And eventually this leads to atherosclerosis, increased systemic inflammation, and eventually insulin resistance, and I'll get into that in a little more detail so it makes more sense to you. Cardiovascularly, what we're all familiar with are some of the effects on the cardiovascular system in and of itself. A couple of meta-analyses are out there. I chose this one particular one, and certainly what it says and the others were saying pretty much the same thing, is that obstructive sleep apnea causes an increased risk of stroke. It also causes an increased risk of death to some cardiovascular interaction. It also strongly supports or suggests that there's an increase in ischemic heart disease, and that kind of makes sense when you think about what I just told you in terms of the pathophysiology there. However, and this goes back to what I said before, I also thought it put you at increased risk for hypertension. Well, that's changing. And on that note, I'll also say what I tell you today and this week may actually be different a year or two from now with all of the things that are happening in terms of research. There are 3 studies that came out in 2012, 2013. Good studies, well-developed, published in good, respected journals, using different criteria, different populations, but all 3 of them came out and questioned whether obstructive sleep apnea truly has an impact on hypertension. So that is currently under review, and people are starting to backtrack a little bit from that. So be aware of that possibility that they may be changing that statement on down the line. Who knows? What I did find was kind of interesting. There was this one study by a fellow by the name of Mason who looked at abdominal aortic aneurysm expansion. And what he found was that men, and it was strictly men in this case, who had abdominal aneurysms, small aneurysms, and there were some who had no obstructive sleep apnea by criteria, mild obstructive sleep apnea, or severe obstructive sleep apnea, and he watched them over a 5-year period. And what he found was that those with severe obstructive sleep apnea had significant expansion of that aortic aneurysm. That was not true in those without obstructive sleep apnea. That was not true in those with mild obstructive sleep apnea. Only those with severe obstructive sleep apnea, several of which went to surgery for that expansion. So kind of an FYI thing. The effects on the metabolic system are pretty expansive as well. We know that adipose tissue now is a very active endocrine organ in and of itself, and they think that this may be how it enhances the effects of obstructive sleep apnea. It produces mediators that can affect neurohumoral changes because of that fat. And you have this term out there now called diabesity, and what that means is the body fat is influencing the modulation of obstructive sleep apnea on glucose metabolism. And what typically happens is that it starts off that these mediators from the adipose tissue starts to reduce the secretion of insulin itself. Over time, then, you develop intolerance to glucose, and eventually this is what leads to insulin resistance and its negative pathways. Now, what's interesting about this is that, yes, people who are lean and have obstructive sleep apnea can have these metabolic derangements, but it's only if you're obese do you tend to get to this point of insulin resistance at a much faster state. You can get there if you're lean. You're less likely to if you get there if you're lean, but certainly we're seeing in those who are obese. So this is where the thought is that with obstructive sleep apnea, obesity tends to escalate the problem. On the neurocognitive front, and I kind of find this one more interesting, is that there's no doubt from what the literature says right now, that it does have an impact on memory, lack of attention. It has an impact on executive function. This is your ability to think about things organizationally, to be able to retain information and then retrieve it afterwards, that is impaired. Increased incidence of accident, either because you're not paying attention to something or the neurocognitive issues there. What was interesting is that they have documented a loss in the gray matter in and of itself. And yet, one study looked at CPAP. If you give CPAP to somebody who has early onset obstructive sleep apnea and you document this loss of gray matter, you can actually reverse that process with the CPAP, and you'll get return of that gray matter as well as return of improved function. So a lot of times what I've heard and I've read is that CPAP is really only good because it improves your ability to ventilate the patient. There does seem to be some positive impact to giving somebody or getting somebody started on CPAP in and of itself. Kids are also at risk for obstructive sleep apnea, and they have some very dire effects from this. Usually the reason for the obstructive sleep apnea has something to do with the tonsillar hypertrophy. But if it's left untreated, they have documented that, again, you have loss of cognitive function and they produce lower IQ results. The impact of that for that individual can be life-threatening, or life-changing, rather, I should say, in terms of their ability to do what they would have been capable of doing otherwise. Now, this next slide is not meant to make you nauseated, but to show you the impact of obstructive sleep apnea on the entire body. Frances Chung is well known. She's up in Toronto, and she's well known for the work she's done on obstructive sleep apnea and anesthetic implications. She gave a lecture a couple of years ago that I heard, and she made the claim during that lecture that obstructive sleep apnea will take 20 years off of your life. It is worse than tobacco. And at the time, I wasn't so sure that I believed that, but the more I'm learning about this and seeing of it, the more I'm beginning to believe that probably does have a ring of truth to it itself. The effect of stroke, 90%, the percentages here are increase over base, and I think sometimes it's a little bit high, but 90% more frequent stroke in somebody with obstructive sleep apnea. This is all the cardiovascular type of effects that you can see with obstructive sleep apnea. Over here, the neurocognitive issues where you can get into mood disturbances, depression, anxiety, daytime sleepiness, which can lead to accidents happening and an inability to function because you're so tired during the day. Diabetes, obesity, reflux, sexual dysfunction, urinary tract dysfunction. It is estimated that an individual, or the cost for an individual to receive medical care during the course of a year, costs about $200,000 to the system. That's $200,000 to the system per year. Multiply that by 20% of the population. This is a huge health problem, and it's no different in the OB population itself. Same kind of incidence. You see 15 to 25% of the OB population probably has obstructive sleep apnea. Those are what the numbers are, so 20% makes sense there. But moms are just as likely to get into this systemic inflammatory response, the insulin resistance, as anybody else is. So what do we see in the OB population? I took two authors here. There are a number of studies out there, again, very hard to compare one against the other. But I chose these two studies looking at maternal effects due to obstructive sleep apnea, and partly because they looked at many of the same things. Lewis found a much higher incidence of preeclampsia if you had obstructive sleep apnea versus if you didn't. Same thing with Uygar, who is out of Turkey. Uygar also looked at gestational diabetes, 4 times the incidence of gestational diabetes if you have obstructive sleep apnea. Lewis didn't look at it, but a number of other authors looked at it and said the same thing, that this was also what you tended to see. Much higher incidence of cesarean delivery if you have obstructive sleep apnea. Oh, what happened there? Everything just went down. There we go. Oh, you know what? Make sure that's tight there. There we go. I got it. Yeah. Much higher incidence, like double the C-section incidence. Uygar, I thought this was fascinating. Turkey must have an outrageously high C-section rate, 51%. That's if you don't have obstructive sleep apnea. But much higher again if you do have obstructive sleep apnea in that population. And then Lewis also looked at the NICU admission rate for these kids did not do as well, and I'll get to that in just a second, but again, much higher, and all of these things have a huge economic impact on the health system in terms of cost to the system. Not surprisingly, the other studies also supported things like chronic hypertension was higher, gestational hypertension was higher, which I found interesting given the new information I just told you about where they said hypertension and OSA may not be interlinked. Elevated pulmonary pressures, no surprise there. Nocturnal asthma, problems with anxiety and panic attacks. And interestingly, what they found here was that CPAP, again, for these mothers, improved the nocturnal asthma, improved the anxiety and the panic attacks. So again, more than just ventilation, it seemed to have a more positive effect on those aspects as well. For the fetus itself, what you tend to find is they tend to be small for gestational age. Now, the odds ratio on these are pretty significant. So if you have obstructive sleep apnea, the odds ratio that you will have a small for gestational age child is 1.34. Preterm delivery, odds ratio is 2.31 with obstructive sleep apnea versus normal. Low birth weight, much higher as well. One study, and I thought this was particularly interesting because it was kind of the question that I had, went back and took a look at mothers with obstructive sleep apnea. When they sleep at night and they desaturate, do you see an impact on the fetus? And he only looked at about 30 women, but did not find episodic impact with mom's desaturation when she slept at night, despite documenting that she would get significantly hypoxic during her sleep time. However, it obviously has an impact because you're seeing the effects of it later on in terms of size and birth weight and preterm delivery itself. But I thought that was very, very interesting. So what about the assessment here? Gold standard is a polysomnography, or PSG as it's better referred to, and I can better say the word. However, it requires a lab. It requires that the patient sleep in the lab overnight, and it requires that a technician be there to monitor the patient during the course of this lab study. And of course, they hook you up to all sorts of lines and things, and then they tell you, just sleep like you do normally at home. Don't mind us, which is nearly impossible. But the end result is, here you are, wired up. They're measuring an EEG, they're measuring the movement on your eye, they're measuring your desaturation. And again, what's fascinating here is that the technician, it's very dependent on what the technician has been told the criteria is in terms of what constitutes desaturation, what constitutes hypopnea. Apnea is pretty well understood there. But how that technician reads this study is highly variable, and that also contributes to part of the problem here. What they measure, REM is not really associated with obstructive sleep apnea, but what they have noted is you don't get into that good, deep REM sleep with these sorts of things. It tends to be a much lighter sleep. But desaturation, which, as I said before, is associated with pro-inflammatory conditions, and you can kind of see how it sets up there. Some criteria is once you get below 89%, that's considered desaturation. Other criteria says not till you get to below 60, which is pretty significant there. Snoring, they do not assess snoring. And as one person put it, snoring is like porn. You know it when you hear it. But there's no criteria attached to it, so they pretty effectively ignore the snoring aspect of this. But what you all see and what they all talk about is this apnea-hypopnea index, or AHI. And this is the average number of episodes that occur during the course of an hour of sleep. Anybody who has less than 5, even though it's interesting that you're having these apnea, hypopnea episodes here, is not associated with disease, so they don't even consider it. It's when you get above 5 episodes an hour that you start looking at various degrees of disease. And again, the interplay from study, because the criteria is used is different, makes the whole thing rather difficult. But once you get to where you're having a lot of this, like over 30 episodes an hour, then it's pretty obvious that you have severe disease going on. So our problem is most people are not going to have this done. and they show up for surgery. In my institution, actually everybody who shows up for surgery gets screened for obstructive sleep apnea using a questionnaire. Anybody else have that going on? All right, that's good. Let me go through what those questionnaires are so you kind of understand what they do and what they're actually providing you with. Now, because of the lack of lab studies, the first one that came out was the Berlin questionnaire. And this one is basically 3 categories. It's 11 questions in those 3 categories. And it was snoring-based and fatigue-based is really what the questions were all about. The problem with the study, and probably why it's not really taken off, it's got a very complex scoring system. So a lot of people have not bought into it. The ASA came out with one in 2006. Again, 3 categories, series of questions. The 3 categories is what's your exam, and you got so many points on the exam. What's your snoring history? So again, it's going back to what you can be told about the snoring history and the history of fatigue. Somewhat familiar with the Berlin system, but the scoring system was less complex. I suspect it didn't take off simply because Frances Chung was coming out with her questionnaire at the time, and it was very easy to kind of put together and very simple scoring system in and of itself. Initially, she just came out with the STOP questionnaire. That was her first thing. And she described it as, S is for snoring, but it's not, do you snore? It's more, do you snore so loudly everybody refuses to sleep with you? You're so loud that if I close the door, I can still hear you in the next room. It's that kind of snoring. Tired? Do you have to take a nap every day? Not, oh, I feel a little, exhausted after lunch. Do you have to lay down and actually take a nap, or you feel you just can't function anymore? That's the tired. Observed obstruction is for O, and are you hypertensive was the other aspect of that. With time, she brought in these other 4 components here, your size, your age, your neck circumference, and if you're male, I'm sorry, you're at risk for obstructive sleep apnea. Her scoring system was if you have less than 3 of these criteria, if you say yes to less than 3, you are at low risk for obstructive sleep apnea. 3 or more, you are at high risk for obstructive sleep apnea. So how sensitive and specific are these studies, these questionnaires? So one study went and took a look at it, and with people with diagnosed obstructive sleep apnea using PSG, they took these folks and they used either a portable monitor on them, which is something that is bedside. It's not as extensive as the PSG, but it looks at desaturation and apnea episodes there, and they did the 2 questionnaires. And what they found is that even though the monitor was not hugely sensitive, it was very specific for obstructive sleep apnea. But nobody has a bedside portable monitor that they're going to go home and they're going to use. So you end up falling back onto these questionnaires. And the questionnaires in and of themselves, both the Berlin and the Stop Bang, were wonderfully sensitive for obstructive sleep apnea, but they weren't specific. So for instance, if you are a male over 50 with a little bit of hypertension, this questionnaire says you're at high risk for obstructive sleep apnea. Now, if you have obstructive sleep apnea, it's saying it's sensitive for that, but how many guys are out there who are over 50 with a little bit of high blood pressure who really have obstructive sleep apnea? It's not very specific. Frances Chung, recognizing that this was the issue, and to her very good credit, hypothesized that if you were having a significant number of these apnea, hypopnea episodes, wouldn't you be developing significant amounts of times with hypercarbia, and wouldn't that have an effect of raising the bicarb value? So she went back and took people who had diagnosed absolute obstructive sleep apnea, and she looked at their serum bicarb level. And she claimed, and this is fairly new data, this just came out last year, she says that if you look at the serum bicarb data and you've got a positive on the Stop Bang questionnaire and their bicarb is 28 or above, you have improved the specificity of this particular technique. And that's easy enough to take a look at. And I think more data needs to happen, but it's an interesting kind of segue into how we're going to determine who's at risk for this and who's not. What about management? As I said before, most of our OB patients are not going to be diagnosed for this. I'm not aware of any obstetricians that are out there screening their patients for obstructive sleep apnea. They're just not in their vocabulary there. And so right now, the only thing you have, if somebody does have obstructive sleep apnea, is you're going to recommend that you put them on CPAP, because frankly, right now, there's nothing else out there. They're trying to do more research to come up with a pharmaceutical approach to this, but there's really nothing but the CPAP. And think of it, you know, you're 20-something, and they want you to put a mask on your face every night when you go to sleep. Very unromantic. I just don't think it's going to go anywhere. So, principles for consideration really come down to screening these folks for obstructive sleep apnea, and then avoiding opioids is probably mainstay, as is airway. Now, I did this slide and this talk before the ASA came out with their new revised guidelines just in January, and I'm very happy to say they agree with me. Basically, they said, go with regional technique. We're in a great field for this. You do OB anesthesia, you're going to do regional technique. Avoid the sedatives. Yes, we do that. They questioned the use of oxygen, and the point they were making in the guidelines was when you give somebody oxygen, they're already kind of desensitized to the high CO2 levels, so they're more likely to stay in a saturated state and have more of a problem if you give them oxygen. So they actually, that was their reasoning to stay away from oxygen. But they said maximize the use of non-opioid analgesics. That's the same thing as avoid opioid analgesics. And then airway. Consider the use of CPAP. Get them in a head-up position as much as you can. There's no question that patients with obstructive sleep apnea have a tendency to have a bad airway. We've all seen it. We know they're a problem. Their exam tells us this. Well, what's the other thing about the obstetric population? They also have a tendency to have a bad airway. So it's really important to pay attention to that airway regardless of what you're doing. Labor, I wouldn't change anything. Even that low-dose opioids that we use for our labor should not be a problem, has not shown to be a problem. I don't think you need to change anything for a labor analgesic in these kinds of cases. Where you're going to get into issues is somebody who is contraindicated for labor analgesia or neuraxial analgesia. And I would not just turn them over to the OB and say, not my problem. It is. You're still going to have to get involved with this. And I'm not wild about remifentanil for IV PCA, but I think this is the perfect indication for it because it's only there for a little bit of time. One-on-one nursing, there are plenty of protocols out there, and I don't have the time to go through them anyway, but make sure they're up in bed. And in this case, I would use oxygen. You know, you've got a nurse there watching them anyway, and you've got you're monitoring their saturation, but I would put them on oxygen for the duration of their labor and that remifentanil protocol. What about surgery? I still will go ahead and give neuraxial opioids. My typical dose is 150 mics of Duromorph, and I would continue to do that. What I would probably not do is send them off the labor delivery floor until a certain amount of time has gone on, because I don't know about you all, but in all the places that I've been, I've never seen postpartum nursing cover a patient as closely as they do on the labor floor. And this is what you want to watch for, is while they're under the effects of the Duromorph, just to keep an eye on them. And that's better done on the labor floor if you can do it. The other thing is tap blocks. I'm not particularly adept at tap blocks, but if you are, this is a population to consider. But again, it's an obese population generally. And those can be a little bit more difficult to deal with. And so maybe later on when we have that lecture, we can talk a bit about that. And finally, what I get on the residents for is that if you're going to go to surgery for these kinds of cases, make sure you ramp the patient. So often I see somebody who's obese, has obstructive sleep apnea, we do our neuraxial anesthetic, and then they lay them down and they're like this. Now, if something happens in the middle of the case, how are you going to manage that airway? And I can talk about what I do to ramp later on. I'm not going to take the time, but be proactive. Think ahead. Get these people maximized if you're going to surgery. So summary, yes, there's an impact of obstructive sleep apnea on this population. You tend to see more hypertension, preterm labor, diabetes. It's very prevalent. It's no different from the rest of the population that's out there. But think about your opioids when you do these cases, and please, please, please think about your airway. Thank you.